Approach to abnormal liver blood test. A 55-year-old male patient present to his general practitioner for routine blood test. He is asymptomatic with no recent significant health changes. The results show abnormal liver blood test, promoting further investigation. Occupation, office worker, sedentary lifestyle. Symptoms, no specific symptoms and he was asymptomatic. Medical history, hypertension control with medication, no history of liver disease. Social history, drinks alcohol socially, consuming approximately 10 to 15 units per week, non-smoker. Family history, no family history of liver disease. Medication, amlodipine for hypertension, no over-the-counter medication or supplements. Examination findings. General examination normal. Abdominal examination soft, non-tender, null-palpable liver edge, no splenomegaly. No stigmata of chronic liver disease such as jaundice, spider nevi or Palmer erythema. Initial blood test results. Liver function test. ALT elevated at 85 units per liter. Normal range is 7 to 56. AST mildly elevated at 55 units per liter. Normal is 10 to 40. Alkaline phosphatase normal at 75 units per liter. Normal 44 to 147. Bilirubin normal at 12 micromoles per liter. Normal range 1.2 to 17 micromole per liter. Gamma GT elevated at 90 units per liter. Normal range is 10 to 50. The GP faces the challenge of abnormal liver blood test in a patient without significant symptoms. Given the elevated ALT and gamma GT, the differential diagnosis include 1. Non-alcoholic fatty liver disease. Common in patients with metabolic syndrome, particularly in those with sedentary lifestyle and alcohol consumption. 2. Alcohol-related liver disease. Possible due to the patient's alcohol intake, although consumption is moderate. 3. Medication-induced hepatotoxicity. It is less likely as the patient is on minimal medication with no known hepatotoxic effects. 4. Viral hepatitis. Unlikely in an asymptomatic patient but should be ruled out with serology. 5. Autoimmune or other rare causes. Less likely but could be considered if no other cause is found. Next steps in investigation. Repeat liver function test in 3 months to assess whether the liver enzyme elevation persists. Abdominal ultrasound to rule out structural abnormalities such as fatty liver, gallstone. Viral hepatitis serology, hepatitis B and C to exclude infection. Lifestyle modification. Counsel the patient on reducing alcohol intake and increasing physical activity to improve liver health. Follow-up plan. The patient was educated on lifestyle changes, particularly limiting alcohol intake, increasing physical activity. Repeat liver function test in 3 months showed a mild reduction in ALT and gamma GT, consistent with improving liver health. No signs of structural abnormality were found on ultrasound. The likely diagnosis was early stage non-alcoholic fatty liver disease managed with lifestyle modification and regular monitoring. Key learning points. Abnormal liver blood test often present in asymptomatic patients. The most common causes include non-alcoholic fatty liver disease and alcohol-related liver disease. A thorough history examination and stepwise investigation are key to narrowing down the cause. Lifestyle intervention can significantly improve liver health in early stage conditions like non-alcoholic fatty liver disease. Differential diagnosis. Non-alcoholic fatty liver disease. Exclusion or confirmation. History of obesity, diabetes, dyslipidemia or metabolic syndrome. Ultrasound show fatty infiltration of the liver. Exclude alcohol history and viral causes of liver disease. Elevated ALT more than AST ratio, typically seen in non-alcoholic fatty liver disease. Liver biopsy in unclear cause. Differential diagnosis 2. Alcoholic liver disease. exclusion or confirmation. Detailed alcoholic history, especially chronic heavy consumption, and AST levels. Ratio more than 2 typically seen in alcoholic liver disease. Signs of alcohol dependence or withdrawal. Improvement in liver function test with cessation of alcohol. Differential diagnosis 3. Viral hepatitis, hepatitis B and C. Exclusion or confirmation. Ask about high-risk behaviors, IV drug use, unprotected sex, etc. Blood test, hepatitis B surface antigen, hepatitis C antibody, hepatitis B or C PCR for viral load. Hepatitis A serology in acute cases. Differential diagnosis 4. Drug-induced liver injury. Exclusion or confirmation. Detailed medical history. Example, paracetamol, non-steroid anti-inflammatory drugs, statins, antibiotics. Discontinuation of the suspected offending drug and monitoring for liver function test improvement. Consider N-acetylcysteine for paracetamol overdose. Differential diagnosis 5. Autoimmune hepatitis. Exclusion or confirmation. History of other autoimmune diseases or family history. Blood test. ANA, ASMA, IgG, liver biopsy. Definitive in unclear cases. Consider empirical treatment with steroids in high suspicion cases. Differential diagnosis 6. Hemochromatosis. Exclusion or confirmation. Family history of liver disease or other iron overload symptoms such as skin pigmentation, diabetes. Blood test. Serum ferritin, transferrin saturation. Genetic testing for HFE mutation. Liver biopsy in cases of diagnostic uncertainty. Differential diagnosis 7. Wilson's disease. Exclusion or confirmation. Young patient with liver dysfunction, psychiatric symptoms or neurological signs. Serum cellular plasmin. 24-hour urinary copper. Case of Flechier rings on slit lamp examination. Liver biopsy or genetic testing for ATP7B mutation if necessary. Differential diagnosis 8. Primary biliary cholangitis. Exclusion or confirmation. Predominantly seen in middle-aged women. Symptoms: fatigue, pruritus. Blood test: antimicrobial antibody AMA, elevated alkaline phosphatase ALP. Liver biopsy if diagnosis is unclear after serology. Differential diagnosis 9. Primary sclerosing cholangitis. Exclusion or confirmation. Strong associated with inflammatory bowel disease, especially ulcerative colitis. Symptoms: pruritus, jaundice or fatigue. Blood test: elevated ALP. Imaging: MRCP, magnetic resonance cholangiopancreatography or ERCP, endoscopic retrograde cholangiopancreatography. Liver biopsy if necessary. Differential diagnosis 10. Hepatocellular carcinoma. Exclusion or confirmation. Suspected in patient with chronic liver disease or cirrhosis. Symptoms: weight loss, abdominal pain, jaundice. Imaging: liver ultrasound, CT or MRI. Serum alpha-fetoprotein. Biopsy if imaging is inconclusive. Step to approach this case. History. Alcohol history. Ask about quantity and duration of alcohol consumption. Medication history. Over-the-counter and prescribed medication, including herbal supplements. Wilder risk factors: IV drug use, unsafe sex, tattoos, blood transfusion, or recent travel. Family history: hemochromatosis, Wilson's disease or autoimmune diseases. Symptoms: jaundice, abdominal pain, pruritus, fatigue, nausea, or weight loss. Other risk factors: diabetes, obesity, recent weight changes, and history of fatty liver. Examination. General physical examination looking for signs of chronic liver disease, jaundice, spider nevi, palmar erythema. Abdominal examination: hepatomegaly, splenomegaly, ascites, tenderness. Investigation. Initial liver function test: ALT, AST, ALP, gamma GT, bilirubin, albumin, PT-INR. Viral hepatitis serology. Autoimmune panel: ANA, ASMA, AMA. Iron studies: ferritin, transferrin saturation. Copper studies: ceruloplasmin, urinary copper. Imaging: abdominal ultrasound, MRCP if biliary obstruction is suspected. Genetic testing for hemochromatosis, Wilson's disease if relevant. Diagnosis. Based on history, examination and test results, aim to narrow down the diagnosis. Prioritize most likely diagnosis based on the platform of liver function test and risk factors. Example, fatty liver, viral hepatitis, autoimmune, etc. Management. Management depends on the final diagnosis but typically involves supportive care for liver dysfunction such as avoiding hepatotoxic drugs, lifestyle modification for fatty liver, weight loss and exercise, specific treatment for underlying causes, antivirals for hepatitis, steroids for autoimmune hepatitis, chelation therapy for Wilson's disease, etc.